All right. Well, let's begin. So as I say, today's lecture will be about ocular trauma. This is one of the most common reasons that people with eye problems present, particularly to emergency departments, but definitely to GPs as well. So you need to be au fait with this material. Where does it fit on your curriculum? You may have seen a version of this at some point in one of the lectures. There's all the ocular trauma presentations clumped into one sort of subheading, if you like. They're both a cause of red eye and they're a cause of visual disturbance. And yeah, I would say not rare at all, fairly common if you work in an emergency department. And they're the conditions we'll go through today. So we'll talk about the general approach to ocular trauma. Okay, how do you think about ocular trauma when someone walks in the door? And then we'll go through the conditions that you actually need to know. There's 6 of them. And I'll just reiterate some of the main points at the end before we do a bit of question and answer. So look, what's the general approach? General approach is when someone comes in with a red eye, broadly speaking, it's either traumatic or it's not traumatic. And the vast majority of the time, that's going to be evident in your history taking. So over 80% of the time, you'll know. So you've got a tradesman, as we heard about earlier, who's been grinding. Instantly, that's metal foreign body, right? Until proven otherwise. Because his history is going to be about acute pain, the eye's going to water, and his vision will be blurred. They're the 3 things. It's not going to be a grumbling course. It's more or less going to be instantaneous, which is most often the case with trauma, as it is in any other part of the body. You know, you've got normal tissue and then suddenly you've got a traumatic laceration or an abrasion or a puncture of some sort. So we'll obviously talk about trauma, non-traumatic causes of red eye. Either it's an infection or it's not, or it's neither of those 2. And that's covered in a couple of lectures that are online on red eye. So please review those. Okay, so that's one approach. The other approach is always the anatomical approach. And this should be fairly intuitive as long as you know some basic anatomy. In ophthalmology, we think from front to back, okay? So the frontmost tissue is the lids and the lashes. Yep, you can have a laceration of the lid. That's fairly common. Next, we think about the cornea. That's the next most posterior structure. Corneal injuries are common. You can have an abrasion or a scratch, a foreign body on the cornea, which we've heard about. And you can also have chemical injuries, which are fairly common as well. Then we've got the conjunctiva, okay? That's the translucent tissue on top of the sclera. Sclera is white. The conjunctiva is actually more or less see-through. It is vascular. That's why you see blood vessels when you examine an eye. They're running in the conj. So the conjunctiva can be cut with, so a laceration, and there can be a hemorrhage. So a subconjunctival hemorrhage is a common association with any ocular trauma. If you whack an eye, the conjunctival vessels are going to bleed. So you get a red eye, that's blood from a conjunctival hemorrhage. So it's a sign that often associates many causes of ocular trauma, is a subconjunctival hemorrhage. Subconj hemorrhages can happen spontaneously as well. Often they do for no reason, just a burst blood vessel. If there's no history of trauma, they're generally innocuous. So a subconj hemorrhage in the absence of trauma is usually self-limiting, will go away on its own. You'll probably know someone that's had one if you ask around. Okay, what's after the conj? The anterior chamber. Okay, so this is the fluids-filled space in between the cornea and the iris. And in the anterior chamber, you can get blood accumulating. And when that happens and there's a fluid level, I'll show you many pictures of those soon. So blood fluid level in the anterior chamber is called a hyphema. Hyphema is not a diagnosis, it's a clinical sign. And again, pretty much any cause of ocular trauma can give you a hyphema. But you've got to have reasonable force to cause a hyphema. That's a sign of like moderate to severe trauma. Next is the sclera, which I talked about. And if the sclera is breached, that's a really bad injury. So you can have a scleral laceration, which is partial thickness, or you can have penetration of the sclera or rupture, in other words. So punching a hole in the sclera, or you can have perforation, which means that you've got an entry hole and an exit hole. So, a sharp piece of wire can do that, right? So again, we're talking very serious injury now, definitely going to be surgical management, going to go to theatre, not just be managed medically. What have we got after that? Let's move to the image on the right now. So this is a picture of the bony orbit, okay, the eye socket. And the most common injury here is an orbital fracture, most commonly the orbital floor, where you get what's called a blowout fracture. So you get a break in the floor of the orbit. And very often this will be associated with a hematoma. So you get a blood collecting within the orbit. Now the orbit's made of bone, so it's a limited, it's a hard limited volume. As soon as you get blood collecting in the orbit, you've got the potential for a compartment syndrome, which means the rest of the contents in there are going to be squashed, the most crucial one being the optic nerve. So you can get a compressive optic neuropathy, which definitely can blind someone unless it's treated pretty quickly. So retroorbital hematoma, important condition, we'll talk about that. So that's your anatomical approach, right? If you're stuck, always think front to back. Is it going to be lids? Is it going to be cornea, conjunctivis cleara, and so on, and that'll get you out of trouble. I could go more in depth, but for your purposes, this is enough. Okay, on the image on the bottom right, here's another approach. Either the globe is open, so the wall of the globe has been breached, or it's closed. And then there are sort of subsets of what type of open or closed injury you've got. I think if you just think in terms of open or closed and surgical or non-surgical, that's a good enough start, because that'll trigger who you're going to call and what you're going to do, whether you're going to fast them, and that sort of thing. So as I said earlier, history is 80% of the diagnosis. So for example, if I've got a patient who's come in, doctor, I was cleaning the bench top and something splashed in my eye. Okay, well, obviously we're thinking chemical injury, right, from the cleaning solution. If you've got someone that's coming from a high-speed motor vehicle collision, I'm thinking orbital fracture, intracranial injury, possibly ruptured globe, this sort of thing. So be guided by the history, not just in real life, but for your OSCEs as well. Sometimes we'll give an OSCE trigger that says, here's a patient that was gardening and suddenly they had pain in their eye as they bent over to prune their rose bush. I don't want to hear diabetic retinopathy, right? Which happens in OSCEs. People are stressed. So do pay attention to those triggers or stems that you get in the history in your OSCEs. The other thing about trauma is that it's definitely a continuum of pathology. So you can have a corneal abrasion plus a subconjunctival hemorrhage plus a high femur plus a scleral perforation somewhere. So it can go from the most innocuous subconjunctival hemorrhage, let's say, to the most severe orbital fracture plus ruptured globe. And so one instance of trauma can give you multiple signs. So think about trauma as a continuum. I've got a scratch on my cornea, the whole eyeball has, ruptured. Don't forget your basic life support stuff, okay? So real life plus OSCEs. Don't forget, people often do, but keep that in mind. And then, as I say, your general diagnostic therapeutic approach, penetrating or non-penetrating, surgical or non-surgical. Any questions about any of that? That's our general approach. Let's get into the core conditions then. 6 conditions, as I say. And in a sense, this represents the continuum that I was talking about, starting with corneal abrasion. So that's not the first condition I'm going to show you, though. So look, these are 3 images of different severity from the same cause or same etiology. Looking at the image of the man's eyes, your top left, any initial thoughts on what the cause could be here? You've got both eyes affected, right? So obviously something that's affected his whole face. His lids are swollen, if you agree with me. And from what you can see, his eyes appear red. And not only are his eyes affected, but definitely his skin is affected as well. Any thoughts on what could cause that? Who thinks, I'm going to give you 2 options, mechanical or chemical, right? Mechanical means a punch or a fall or something. Chemical means some liquid, let's say, splashing into his face. Who thinks mechanical? Who thinks chemical? Yeah, good. All right, we've got a sensible crowd. Great. So this is a typical chemical injury sort of presentation. Both, lids affect, it can be unilateral, obviously, but often it is bilateral. The image on the right, you've got an area of the cornea staining with green. That's an area of fluorescein uptake, most of you probably know, which means that whole part of the corneal epithelium has been lost. That's a massive corneal abrasion. And in this case, it'll be a chemical corneal abrasion, right? He's lost his epithelium because either alkaline or acidic substance has killed those cells and they've sloughed off, right? The image at the bottom looks less angry because the eye is white, but this is actually a really dangerous presentation. We call this a porcelain white eye. And this is where the eye has been damaged so badly by chemical injury that you've actually lost your vasculature to what we call the corneal limbus, right? That's the edge of the cornea, between the cornea and the sclera, which is the most important blood supply for the cornea. So the whole cornea being, the whole conj being blanched is not normal. This person's got what we call limbal ischemia. That cornea is now ischemic. This person's going to need limbal stem cell transplant surgery to try and save their cornea, if not a corneal graft. So the learning point there is if you've got a chemical injury but the eye looks white, it's counterintuitive. That's not a good thing. That's a bad thing. You'd rather the eye looks red, okay? So more urgent. The bottom one is the most urgent presentation out of these three. So let's talk about chemical injury. Splashback is the most common thing. It can be alkaline or acidic. Alkaline is worse, and we'll talk about the causes in a moment. Like all trauma, as I've mentioned, this is an acute presentation. It can be one eye or both. Obviously, they get pain, they get watering, they get blurred vision. Those three things are common to pretty much all ocular trauma. As far as acidic versus alkaline, yeah, so car batteries, refrigerants, and pool cleaners, they're probably the three most common acidic chemical injuries. And then work site injuries, so as in building sites, are probably the most common cause of alkaline injuries. So things like plaster, mortar, cement, lime, all those things are used on work sites. They're probably the most common cause. The other one is airbags being deployed in cars. The powder that's around those airbags is alkaline. So people often get alkaline eye injuries from car accidents for that reason. As I say, alkaline is worse. Both of these need to be irrigated. The mainstay of management for chemical injuries is irrigation with either saline or Ringer's lactate or generally whatever's available in ED. This device here in this uppermost image is called a Morgan lens. That's the plastic lens connected to some tubing that you then connect to your bag of whatever solution you're using. And obviously you want to anesthetize the eye first. You don't stick a plastic contact lens on an eye that hasn't been anesthetized. So you need to be familiar with what a Morgan lens is. We might show you an image in an OSCE and you'll need to use them in real life in the emergency department. The bottom image here shows a badly scarred and vascularized cornea from a bad corneal injury, okay? So you can end up with blindness from chemical injuries, and they end up being one of the most common causes of corneal transplant surgery. So that's what we're trying to avoid. We're trying to avoid the cornea becoming so scarred that the person ends up needing a transplant. Examination-wise, yes, you got conjunctival injection, you got a red eye most of the time. Beware if you don't. You can definitely have an abrasion. The lids are going to be red and swollen, and you may also have residual material in the fornices, which means under the top and bottom lids. So part of your management of these people is irrigation, yes, but you also want to take a cotton sterile tip and wet that with some of your irrigating solution and invert both eyelids and gently sweep top and bottom eyelids, okay? So irrigate those spaces under the lids, but also sweep them with a sterile cotton tip to get rid of any residual material like, dust from a work site and this sort of thing. Anything I've missed? I mentioned topical anesthetic, lid aversion and sweep, irrigation, at least 1 liter, okay, if not 2 or 3. There are pH strips available in emergencies, which you can use to measure the pH when you start, and you can continue to measure it, let's say, after every bag. It should be normalizing, yeah. Don't forget oral analgesia. Obviously, this is very painful, so as well as topical. And then you want to discuss it fairly quickly with us. Whether or not we end up needing to see them, very often we will. And we can do lots of things for these people. Topical antibiotics have a role, cycloplegics have a role with comfort, steroids have a role, and then we use oral agents as well, doxycycline, vitamin C, which are involved in collagen synthesis or slowing down collagen breakdown, which is what happens when you've got a chemical corneal injury. And then if it's really bad, then yeah, they'll need to go to theatre for limbal cell transplant or what we call an amniotic membrane graft. So there's surgical options as well. So discuss early is the advice. And in the meantime, you're providing analgesia, irrigation, and mechanical removal. They're the mainstays of management for chemical injury. All right, let's move on to the next one. So look, if we start with the image on your left, what you've got here is a black eye, right? Could be caused by anything. And that black eye can definitely be part of a continuum where you could have as bad as a ruptured globe, right? You've got subconch hemorrhage. If you look intranasally there, you've got, that's why it's red, that's blood, right, under the conjunctiva. So you would say, look, I've got periorbital edema and ecchymoses, black eye, and I've got a subconch hemorrhage. That's what I can see, right? Let's say we now proceed to the second image where we say, here's someone with a similar injury. She doesn't have as much of a black eye, although she does have some bruising on her right cheek, if you look closely. And we're asking her to look upwards, right? We're putting her an up gaze. We're giving her a target up here. And you probably agree with me that the left eye is looking up, the right eye is not, right? And she'll have diplopia as a result because she's getting two separate images. The eyes aren't moving together. So she's going to have vertical diplopia. So in the context of a black eye plus one eye not be able to look upwards, what you've got is a trapped inferior rectus. The muscle at the bottom of the eye that normally turns the eye downwards is trapped, and the most common cause of this is an orbital floor injury, orbital floor fracture, I should say, okay? What we call a blowout fracture. So common presentation, blunt eye injury is the most common cause of this, whether it's a fall, whether it's a sporting injury, an alleged assault. They're probably some of the most common causes of an orbital floor fracture. Top image here shows a high femur. So this can definitely be an associated sign with an injury that's bad enough to cause an orbital blowout, okay? And the bottom image shows surgical repair of orbital blowouts. They often don't need to be surgically repaired. And so usually the maxillofacial guys or the plastics guys will repair these, sometimes with us. And they'll put mesh on the orbital floor of one sort or another after freeing up any orbital fat or the inferior rectus if it's trapped in the orbital floor. The orbital floor acts as a trapdoor. So it's probably there by design. It's the thinnest part. Well, it's probably not the thinnest, actually. The ethmoid, the nasal part is, but it's the part that blows out mechanically the most common. So if you increase the pressure inside the orbit, the floor most often blows out, and it blows out into the maxillary sinus. So it has the effect of increasing the volume of the orbit, which is what you want if you're squashing the eye. You want increased volume. So the pressure on the eye then goes down. But the side effect, if you like, is you can have tissue trapped in the trapdoor. So the eye is tethered at the bottom and can't turn upwards. That's why you get vertical diplopia and a lack of upgaze, right? So they're the sort of hallmarks of orbital fracture. History again, acute trauma, yes, all the usual stuff, but they can get a nosebleed, and then diplopia, as I've mentioned, is the other part of the history. Doctor, I got hit in the eye and I've got double vision now, right? And you say, are the two images side by side or are they one on top of each other? And they'll say they're one on top of each other because it's vertical rather than horizontal diplopia. Yeah. Etiology, blunt eye injury, as I say, from various things. Examination-wise, diplopia and upgaze we've talked about, black eye we've talked about. Bradycardia happens if the inferior rectus is truly tethered, which invokes a vasovagal or a vagal response, I should say, not vasovagal, a vagal reflex, which brings down the heart rate. So inferior rectus being tethered is painful, and the person will become bradycardic. The intraocular pressure should be normal. If they haven't had a retrobulbar hemorrhage, then they should have a normal intraocular pressure, which you can measure with a handheld device called a tonometer in emergency. The pupil may be dilated. If you whack an eye, the iris, usually temporarily, will become mydriatic or mid-dilated. So we call that traumatic mydriasis. So this is a sort of typical combination of signs and symptoms for blunt eye injury. Traumatic mydriasis, possibly a small hyphema, limited upgaze, and so on. Management-wise, you want to image these guys. Make sure they don't have an intracranial bleed, a subdural or a subarachnoid, or cranial hemorrhage. And management of an isolated orbital floor injury, we use nasal decongestants. Okay, so Fess nasal spray or something like that. Tell them to avoid nose blowing, because you've potentially now got a continuous space between the nasal passages, maxillary sinus, and the orbit. And then it's rest, analgesia, ice packs, broad spectrum antibiotics, so you don't get an orbital infection as a result of being exposed to sinuses. We get involved more or less to check the eyeball and document the ocular motility, right? If they're bad enough to have a hyphema, they'll have what we call traumatic uveitis, just inflammation of the eye as well. We'll treat that with steroid drops and cycloplegics. And then there'll be co-management with plastics or maxfax for an orbital floor repair, if that's necessary. Most of the time it isn't. And the surgery generally isn't done acutely. It's done once the soft tissue swelling goes down, which takes a couple of weeks. So the normal course for these guys is conservative management, and within weeks, they're back to normal extraocular movements and so on. Okay, so that's orbital fractures. Common, very common in emergency departments. Now, you probably agree that this all looks much, much worse. So if we think about our continuum of pathology, so far we've had a chemical injury, we've had blunt eye injury resulting in an orbital floor fracture. But here in both of these images, there's a lot of blood, right? So there's massive subconjunctival hemorrhage, 360 degrees around the whole eye, right? So there's a lot of bleeding happening somewhere. And it's actually pushing the conj out. And particularly in the image on your right, you might agree that the eye looks proptosed as well. The whole eye looks like it's being pushed out. So these are really suspicious signs for retrobulbar hematoma or hemorrhage, okay? There's bleeding happening at the back of the eye, which is tracking anteriorly under the conj and pushing the whole eye forwards. This is worse than the two other injuries that we've seen so far, okay? I think there's actually a little hyphema here as well, right? Okay, and so here's a scan showing a retrobulbar hemorrhage of the left eye. You can see that the eye's pushed forwards, right? This is a CT, and the whole orbit is filled up with blood, okay? So that's a typical sort of appearance for retrobulbar. These guys, in addition to the normal history, the mechanism usually will be more severe, but not always. A simple fall can do this, especially for elderly people. And if they're not treated fairly quickly, they'll rapidly lose vision, right? So they may have already report dim vision in the eye. Yeah, etiology-wise, it's blunt eye injury, again, is the most common thing, resulting in a compartment syndrome. The key things here are the proptosis. There'll be lots of hemorrhage and also restricted extraocular movements. That's what EOM is. Because in a sense, the eye becomes frozen by the volume of blood that's in there and the resulting ischemia to the optic nerve and to the muscles. The intraocular pressure can be unrecordable. It can be so high that it's unrecordable. And what you can do is, if you're not able to get a pressure, you put some topical anesthetic into both eyes and just gently with your fingers palpate, get them to close their eyes and palpate the eyes externally through the eyelids. and retrobulbar hemorrhage will feel rock hard, right? Whereas a normal eye, you can press on your own eye. It's a bit squishy. Don't press too hard. But normal eye, you'll get some give. Retrobulbar hemorrhage, you'll get very little or no give. If you suspect a globe rupture, right? If you're worried about a globe rupture, don't palpate the eye, because if you press on it, you're going to squash the contents out. So it's only if the eye looks definitely intact and you've tried to do a gentle tonometer pressure and you can't get one. These guys might well have an RAPD, so a relative afferent pupillary defect, okay? And that's because the optic nerve is already compromised. You're not getting a pupil light reflex on the affected side. And they can well have a high femur as well. The management is an immediate procedure in emergency department, which can be done by an ED registrar or you under supervision, or the ophthalmology registrar if they're there, whoever's there first that's able to do it. It's not a complex procedure. You just need to have seen it and understand what you're trying to do. So the relevant anatomy is this. Here's the lateral aspect of the eyelid, the connective tissue of the eyelids. You've got one tendon here called a lateral canthal tendon. You want to cut through that with a pair of sharp scissors. And then you want to cut through, and then there's a superior and an inferior lateral tendon as well, right? There's a top and bottom supporting tendon and then the biggest lateral canthal tendon. You want to go through the lateral one and you want to go through the inferior lateral one. So it's two cuts. It's one cut laterally, and once you've made that one, it's one cut inferiorly or infratemporally. And when you make these cuts, particularly when you make the second one, you'll actually see the whole globe kind of move forwards, because again, you've just increased the volume that the orbital contents and the eye have access to by getting rid of these hard tendons at the front. You cut those tendons out of the way, the tissue all moves forward and the pressure should go down. So obviously you want to anesthetize. Well, not everybody anesthetizes the area. Some people will just cut. I think it's easy enough to put in some xylocaine with adrenaline. It takes 2 minutes. You know, put in 3 mils or something, laterally and inferiorly. Then you can use some artery forceps to clamp the lateral canthal area. This part is what I'm talking about. I'm just indicating on myself. So you clamp that. So you clamp the tissue. So you're sort of pushing the blood out of it. Helps with the anesthesia as well. Then you get one arm of your scissors under the skin, the other arm's on top, and you cut laterally, okay? And once you've made your lateral, it needs to be a decent cut. It needs to be full thickness, the whole skin. The most common thing that happens in EDs is people don't make a long enough cut or a full thickness cut. So you make a full thickness cut that's at least 1 centimeter long, if not 1 inch long. And then you do similarly inferiorly or infratemporally, all right? You'll have supervision the first time you do this, hopefully, unless you're in a country hospital, in which case you have it talked through on the phone with an ophthalmology registrar, but hopefully it doesn't come to that. That's the mainstay of management, okay? Don't delay, don't go and get imaging before you do this. Do this first and then go and get your CT orbits and brain to look for other stuff and to, help confirm the diagnosis. Urgent referral to us, obviously, for many reasons, plus or minus other people, depending on what else is injured. And then they're going to need antibiotics, analgesia. Acetazolamide is a carbonic anhydrase inhibitor, which reduces aqueous humor formation. So it helps to bring the pressure of the eye down. The pressure in the eye is going to be up. We want to soften the eye, essentially. So acetazolamide helps with that. And then some centers will use hydrocortisone, some won't, for this sort of injury. Any questions about any of that, guys? Yep. Yeah, good question. Not much. So if you think there's a retrobulbar hemorrhage and you make that cut, those 2 cuts, and there isn't, it's really not a big deal because we can suture those. We can suture that skin back together. And sometimes it doesn't need suturing at all if they're not very big cuts. So as long as you're not cutting the eyeball, You know, and you shouldn't be, because your blades should be pointed towards the ear, if you like, away from the eye. The sharp bits of the blade should be pointed away from the eye. There are arteries around there. You know, you might get a bleed. You could just put some pressure on that, and then that can be diathermied later. That's about it, really. So if in doubt, get quick advice on doing a lateral canthotomy catholysis. That's the message. Okay. Moving on, I think we're halfway through. Okay, this is not normal. I think you'll agree. The pupil's not a normal shape. So we call that a teardrop pupil. And the narrow part of the teardrop is pointing towards some brown tissue, which looks like it's outside the eye. Okay, and it is. That's iris tissue, which is prolapsed through a full thickness corneal laceration, right? So now we've got a penetrating eye injury. This is our first case of penetrating eye injury. These are the signs that you're looking for. You're looking for a teardrop pupil, and then you're looking for brown tissue that looks like it's prolapsed out of the eye. It doesn't belong there, all right? So you're going to tell me this is a penetrating eye injury. Maybe it's even perforating. That's probably unlikely. Here's another type of injury which can definitely be associated with a penetrating eye injury. This is a full thickness lid laceration, okay, on the nasal aspect of the lid. Obviously, this is going to need surgery, right, to put that lid back together. And underneath that cut, you're going to be very suspicious of a possible penetrating eye injury. So you're going to say, I've got a ocular trauma case, doctor, ophthalmologist. We've got a full thickness laceration through the lid. They're going to need to go to theatre. I'm fasting them now. I'm going to give them some antibiotics. I'm going to check their tetanus status, right, within the last 5 years. And if they don't have that, we're going to give them tetanus. And I'm worried about a penetrating eye injury. I can't get a very good view. I don't want to press on the eye because I'm aware that, you know, the eye might be ruptured. Could you please come and see them now? So that's your approach. Here's another penetrating eye injury where the foreign body's still there. It's a fish hook. It happens every now and then. People go to cast the line out and you get a hook stuck in your eye. Don't pull that out. We'll do that in theatre, but this is another, you know, these cases are basically, you know, as far as you're concerned, an emergency, these are surgical preparation cases. You're going to prepare these guys for theatre, give them some counselling, keep them safe, make sure no one presses on their eye, okay? That's more or less your management. Here's a high femur again. I'm just putting pictures of high femurs everywhere because to just illustrate this continuum of pathology thing. Lid laceration, subconch hemorrhage, they can all be part of a mild injury or a very severe injury, okay? The usual sort of history, trauma, pain, loss of vision, etc. Usually these are high energy or high velocity with some sort of projectile or object that has a sharpish edge. It's capable of cutting the sclera or the cornea or both. Cornea and sclera are actually really quite tough. You'd be surprised if you try and stick a needle or something in them. It actually takes a bit of force. And the usual sites of rupture are normally at the limbus. So the limbus, as I mentioned earlier, is the interface or the margin between the cornea and the sclera. So that's an area of weakness which can rupture with a blunt eye injury or with a sharp injury. And then behind the rectus muscles, you can't see the rectus muscles here, but they're about 6 millimeters or so set back from the limbus, and they insert into the sclera. And they're the muscles that turn the eye, you might remember. And the tissue underneath the rectus muscle, or where it inserts, tends to be a bit thinner and a bit more prone to rupturing, okay? So a ruptured globe or a penetrating eye injury, they tend to be typical sites for where the rupture occurs. What are the signs you see on examination? The main one is the uveal prolapse and the teardrop iris, teardrop pupil that I mentioned before. But if you've lost volume, then the anterior chamber is going to be shallow, right? And the best way to know that is if you compare it to the fellow eye, right? Have a look on the slit lamp. You're an emergency. You'll see what the normal eye anterior chamber depth looks like. And you look at the affected eye and you should see that it's more shallow, okay? Mention Seidel's sign here. Seidel's sign is when you put fluorescein on the eye. turn on your cobalt blue light and look at them on the slit lamp, and you'll actually see fluid leaking out of the site of rupture or penetration. And it looks like a little waterfall. Looks like a tiny little waterfall actively leaking out of the eye. So then you can say Seidel positive or Seidel negative. If you've got uvea or iris tissue plugging a wound, it might be Seidel negative. There might not be fluid leaking out of it, but do look for it. Hyphema, I've mentioned, you can have an associated orbital fracture and a retrobulbar hemorrhage. So you've got to be mindful that this person may have all of these things. Okay. The mainstay of management here, as I said, is to get them to us as quickly and safely as possible in order to go to theatre. So tetanus, IVABs, put a shield on, not a pad. So this has been put on so that there's no pressure on the eye. You can also cut the end off a cup like this so that the eye can be grossly examined, and so that the person, if they've got a bit of vision, which they often do, they can still get binocular rather than covering up the eye altogether while they're waiting for us to turn up. So yeah, you want to fast them, get some imaging. CT is usually the quickest one to be able to get. Don't get an ultrasound of the eye because that involves putting pressure on the eyeball. And an MRI takes time. So usually the best one to get in the emergency department is a CT. If all you've got is an X-ray, that's okay. Because an X-ray will show us if there's a metallic foreign body inside the eye, intraocular foreign body, which can happen if there's been, say, an explosion, workplace accident, right? Penetrates the eye and then you get metal inside the eye. Then we'll take them to theatre and then repair whatever needs to be repaired. Prognosis very much depends on what was the energy and velocity of the accident and then which structures have been damaged, right? And can be all the way from very, very good, end up with perfectly normal vision. I saw a patient that had been bitten by a shark on the head and had a full thickness laceration of the sclera and repaired the sclera. The rest of his eye was fine, perfect vision, no problems, right? He was a cray fisherman. Another lady fell over, got out of bed, fell over, hit her eye on the corner of her bedside cabinet. So hard wooden edge going into eye, ruptured the eyeball and ended up with no vision. And in fact, ended up having to remove the eye because you damage enough of the ciliary body. Ciliary body is the bit that makes aqueous humor to fill up the eye, to pump it up full of fluid. And if the ciliary body dies, then you've got a flat ball, right? It's like puncturing a soccer ball and it never pumps up again. So she ended up with no vision and in fact, unfortunately, having to have her eye removed. So prognosis is very much dependent on severity of the injury and it's variable. Okay, so that was our last condition. So there's those 6 conditions again. They're the ones that are in your curriculum and you need to know. All of them are painful. I've had 2 or 3 corneal abrasions. They're extremely painful, and that's the least severe of these injuries. Remember your general approach, okay, whether it's in the OSCE or in real life. I've got a red eye, is it traumatic or non-traumatic? Could there be a foreign body there somewhere that needs to be removed and that I'm missing? Could it be under the lids? Is this person going to have to go to theatre or not? How quickly does ophthalmology need to see them? They're the sort of questions you want to be asking yourself. I often tell the story that I saw a 6-year-old child that had been CT imaged for what was thought to be orbital cellulitis because the upper lid was red and the eye was red and angry and very, very painful. Orbital cellulitis is dangerous and it's not uncommon in kids, but no one had looked under the kid's upper eyelid and they just had a foreign body under the eyelid, which had scratched their cornea, giving them a very painful eye, redness, and the swelling of the skin. So do make sure you revert top and bottom lids. If you're worried about a penetrating eye injury or a globe rupture, don't worry about everting the lids because everting the lids involves putting pressure on the globe. Don't want to do that if you're worried about a ruptured eye. And we're going to avert the lids once we've taken them to theatre anyway. So that's the exception to the rule. Everyone else, make sure you avert the lids. Other key messages, yeah, retrobulbar hemorrhage. just be familiar with what a lateral canthotomy cantholysis is, so you know when it might be indicated, and so you can quickly get help. You know, if you're the person picking up the patient, you quickly get your registrar. Everything else, I think. And yeah, chemical injury, just remember the mainstay is irrigation, a minimum of 1 litre, if not 3, and discussion with us. Other resources, there's a medical student, he's a junior doctor now, but he's done a series of podcasts on lots of things, not just ophthalmology. We did a podcast on ocular trauma. You can find it at that website there. We'll reiterate a lot of the stuff we've talked about today. And then the other red eye lectures on YouTube are relevant to today's talk. Final reminders, I think I've put these in some of my other talks, but don't forget oral analgesia. Don't discharge people with steroids or steroid drops or anesthetic drops, certainly not without discussing it with us. We occasionally use anesthetic drops for, say, a corneal abrasion patient. If they're being seen at 2 in the morning, they're going to go home, keep them comfortable till 9 a.m. when we see them in clinic again. But ongoing use of topical anesthetic drops will make the cornea worse, not better. We'll actually give them a toxic corneal condition. So don't be tempted to do that. And that's it for today. Thanks for listening.